My name is Austin Page. The date is July 20th, 2019, and this is my video submission for the Unit 4 Case Connections video presentation assignment for Medical Biochemistry 1. I'll be going over both cases 1 and 3 of the assignment. So the prompt for the first case states, a newborn girl appeared normal at birth, but within 24 hours she developed lethargy, hypothermia, and apnea. The attending physician suspects a metabolic disorder and orders a panel of labs. The question here is, which diagnostic would be the best to distinguish between a urea cycle disorder and a disorder in beta oxidation? Please discuss your rationale for this choice. So there's 4 options listed. The first one is blood glucose, the second is urinary acids, then serum fatty acids, and also plasma glutamine. So the best diagnostic to distinguish between a urea cycle disorder and a disorder in beta oxidation out of these options is plasma glutamine. I came to this conclusion because urea cycle disorders, or UCDs, are representative of a group of abnormal and rare hereditary metabolic disorders derived from a deficiency in one of the elements necessary for the urea cycle. This, in turn, produces ammonia accumulation in nitrogenous products such as glutamine and alanine. Defects in beta oxidation, on the other hand, does not result in a change of glutamine levels. Assessing this key difference, we can correctly decipher whether the defect is attributed to either the urea cycle or beta oxidation. Blood glucose would not present as a helpful diagnostic in this case due to the fact that in the process of beta oxidation, the oxidation of blood glucose feeds into the production of acetyl-CoA, whereas in the urea cycle, glucose does not play a significant role. Therefore, blood glucose alone will not be able to detect the outlying difference between the two processes. For the same reason, urinary acids will be just as ineffective in reaching a conclusion since they are present in the urea cycle while not present in beta oxidation. Lastly, the failure to break down lipids leads to an elevation in serum fatty acid levels. This would show a beta oxidation disorder, but would not present sufficient information to diagnose a urea cycle disorder. So the prompt continues on and says a full blood workup was ordered for this female, and the data is presented below. The initial blood ammonia level was elevated at 314 micrograms per deciliter, whereas the normal range is between 17 and 80, and rapidly rose to 600 micrograms per deciliter. The urine uric acid level was markedly elevated, and the plasma citrulline level was normal. Based on this information, in this patient where uric acid levels are elevated, list one urea cycle enzyme that is most likely deficient and one urea cycle enzyme that is least likely to be impaired. Be sure to justify your answers. So an elevation in uric acid levels in the blood occurs when there is a deficiency in the enzyme ornithine transcarbamylase, or OTC. Thus, OTC is most likely deficient. This enzyme is primarily deficient when there is a blockage in the urea cycle and leads to hyperammonemia, which is a dangerous condition characterized by an excess of ammonia in the blood, as well as decreased blood urea nitrogen. Hyperammonemia is exceptionally apparent when assessing the patient's ammonia levels in the blood workup. The combination of these symptoms is most likely representative of ornithine transcarbamylase deficiency, or OTC deficiency, a rare inherited genetic and severe disorder. The enzyme that will be least impaired is carbamoyl phosphate synthetase. Carbamoyl phosphate synthetase is the enzyme that catalyzes the ATP-reliant synthesis of carbamoyl phosphate from glutamine or ammonia and bicarbonate. When there is an absence or deficiency in OTC, an excess of carbamoyl phosphate is formed and will be converted into uric acid. Carbamoyl phosphate is more of a feeding enzyme into the urea cycle and is not directly impacted by ornithine or OTC on the same level that citrulline, arginosuccinate, and arginine are. Alright, so for case 3, the prompt states, a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are listed below. There's a table with both plasma urate levels and urinary uric acid levels. So normal level for plasma urate is below 7, roughly about 6.8. The patient's is at 10.5, whereas for the urinary uric acid levels, normal is 413 with plus or minus 78, and the patient comes in at 215. So what is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information you may need to decide the root cause. So there's 3 options. The first being overproduction of purines, second is decreased salvage of purines, and 3 is decreased urinary excretion of uric acid. So simply put, just for some background information, gout is a very common form of inflammatory arthritis that usually occurs in the large joint of the big toe, although it can occur in any joint in the body. This includes the elbows, knees, ankles, fingers, etc. Gout develops when an individual experiences high levels of uric acid in the blood and commonly creates needle-like crystals in the affected joints that can produce extremely painful episodes. So gout can become chronic in patients that retain high uric acid levels over the period of several years and can induce joint damage in addition to loss of mobility. So given the understanding that gout cultivates from high levels of uric acid in the blood, the most reasonable explanation would be decreased urinary excretion of uric acid. In healthy individuals, uric acid is dissolved in the blood prior to passing through the kidneys and into the urine. Since the uric acid is not passing through the urine, it is accumulating in the patient's joint and generating the previously mentioned reduced excretion of uric acid is also explanatory for the presence of hyperuricemia, as seen in the patient's urinalysis being far above the normal plasma urate level threshold of 6.8 milligrams per deciliter. So it is possible that the overproduction of purines is partially responsible for the high plasma urate levels, though it cannot be clearly indicated by the information presented since there is no mentioning of a diet high in purines and therefore should not be selected to compete with the notion that the gout was caused by decreased excretion of uric acid. Similarly, there is no outstanding evidence of decreased salvage of purines. It is helpful to note that decreased salvage of purines typically results in production of uric acid, though as long as it is removed from the body, gout would not occur. There's the second part of this prompt as well. It says, after further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda in a single day. There's a note that says the primary sugar in most sodas is fructose or high fructose corn syrup. What is the potential impact of this dietary modification on the presence of gout? So gout is heavily influenced by an individual's diet and is more prevalent in men and those that are overweight or have a high BMI. A diet high in fructose has the strongest correlation in cases of gout, though the consumption of alcohol, seafood, and certain vegetables and beans can also have a significant impact. The patient has admitted regularly ingested an extremely high quantity of fructose in the form of soda. Drinking in excess of diet soda has not been associated to an increased risk factor for gout. So it is most plausible that when the patient switched to soda containing fructose is initially when he started the symptoms of gout began to appear. Depending on other components of the patient's diet, he could have been developing gout prior to switching to regular soda. For instance, if the patient was an alcoholic, he would have been at a much greater risk.